Anyway, what I will do in this presentation, short presentation, is to give you like a set stage so that you will see where different studies will be able to bring in, that you will hear later on, will be able to support Vietnam 3 decades after Doi Moi in addressing the issue of injection drug use and HIV. We'll go very quickly over the epidemics, and then go into more details about the national responses and the key challenges that I see at this moment. In terms of the first section on epidemiology, after 3 decades, the epidemics start around at the beginning of Doi Moi in early 90s. Now, 3 decades later, we have seen a fairly stable epidemic, with the new number of infection is at the level of 14,000 every year for the past few years. We also see a stable number of people who develop AIDS, and also the people who are living with HIV/AIDS. And we have, at the national level, we have kept the infection rate at about less than 0.5% of the adult population. But if you look at the epidemic in Vietnam, it's really not so much a national story, but it's more like a concentrated in key population and also concentrated in key geographical areas. These are the 3 major groups, key population that are affected by the epidemic in Vietnam. And this is this estimate number in 2013, and this is the surveillance, the HIV prevalence. For the IDU population in particular, where we are most interested in, you see the prevalence have gone down substantially over the past decade, right? And now to the level of about 10% at the national level. And this is the data from HIV sentinel surveillance. We have seen in recent years, the past few years, a upswing of HIV among MSM population, and this is going to be the next epidemic of HIV in Vietnam, but also in the region. But if you look in more detail in terms of geography of HIV prevalence, you see that in provinces where the darker red dark, right, that's where the large concentration of injection drug use is. This is in the northwest provinces in the border with Laos and in proximity to the Golden Gate area. That's also a little bit in the northeast, but in the south, Ho Chi Minh City and some of the provinces here is still very heavily affected with high prevalence of HIV. And if we look into more details in terms of the IDU prevalence among IDU in various provinces, here we have 2 provinces you will hear the presentation from, Ho Chi Minh City. The prevalence in 2013, the IBBS, which is a very sophisticated integrated behavioral and biological survey, that the prevalence was 40%, around 40%. And similarly in Hai Phong, which is another area where another study has just been conducted, there also similar 40% among the high-risk provinces in Vietnam. In some of the newer provinces like Điện Biên, which is about 25%, which is much higher than the national level. In terms of HCV, we don't have a lot of data for HCV among the injection drug use. This is some of the earlier paper that our study in Hanoi, and this is the sort of the HIV prevalence over the time of their injection. So the more they involve in injection, the more people get infected, higher prevalence with HCV. And already at the first 10 months, the HIV prevalence already 30%. Right? This is also another result of IBBS. If you look at compared to other groups, male MSM, female sex workers, for ideal, the HCV prevalence is much higher than any other infection, for example, HBV. And this is a study among the patient who are HIV inpatient in Vietnam by Dr. Huy and his colleagues. And we see that the co-infection of HIV and HCV among HIV positive patients is much higher than co-infection between HBV and HIV. And injection drug use is major risk factors for the co-infection. Right? But there are also not just the injection drug use as a single behaviors or as a single group, right? But we also see a lot of overlapping of risk behaviors. This is the IBBS data that show that the proportion of MSM and female worker who ever injected drug very high in Ho Chi Minh City, but also pretty high in other provinces that they have been conducted a survey. This is the smallest study among MSM in Hanoi that we conducted a few years ago. And you see that not just heroin use, but also increasingly MSM are involved in methamphetamine, ecstasy, and some other drugs that are newer in the market. And this is also the IBBS data that show the injection drug use among MSM very high in Ho Chi Minh City, ever injected in Hai Phong about 13%, and similar to Hanoi. Drug use in early 2000, drug use was the major route of transmission among female workers, and it seems like it still remained the same over the past decade. In the low HIV prevalent provinces, you see that the female worker who ever injected drug has much higher prevalence as compared to female worker who never injected drug. But in the high HIV prevalence, it's probably past the stage where injection drug use was the main mode of transmission. Now it's a self-sustained epidemic among heterosexual couples or partners. And this is another example of a most recent study among female sex partner of injection drug use in Ho Chi Minh City. And in that study, they survey about more than 1,000 injection drug users and their female sex partners. And this is the very astounding HIV prevalence among the group. And we see that also female sex partners, probably many of them are female sex workers themselves that live with the injection drug user also inject drug over the past year. And it's the major risk factors. I also want to remind of other drug substance use that's also prevalent. This is a study by Dr. Vivian Goh, and she shows that the less the people inject drug, the more that they use alcohol. That's a very interesting finding that's also show the interaction between different substances. And this is among the MSM. Our study in Hanoi showed that those who have a hazardous drinking level have much more inconsistent condom use as compared to MSM who have less hazardous drinking level. And if you compare the MSM in Hanoi, where our study was conducted, with MSM, with men in Vietnam in general, and also with MSM in Kenya, we see that the men in Vietnam have MSM in Vietnam have a very similar drinking level, hazardous level as MSM in Kenya. So what have been the responses and what are the key challenges? Over the past 3 decades, I think that we have made a lot of progress. As Dr. Jill at the beginning mentioned, there's really a political evolution in Vietnam in terms of addressing drug use and health consequences. At the very beginning of the epidemic, we see that the drug use were considered as social evils and very tied up to HIV and other evils. And people were put in O6 center This is the picture of 06 Center where the resident had to labor after a cold detox. And in 2008, this is very much the picture of early 2000. And in 2008, there was the first, some of the first methadone clinics were opened in Vietnam. And last year, the government approved a plan to renovate all of the compulsory drug compulsory drug rehabilitation centers and turn them into a so-called voluntary center. And how long that would take to transform this center is really up to the question. It's still a big question, but I think that it has shown a very significant change in Vietnam. The methadone clinics since 2008 has really expanded rapidly. Now we have the latest data was about 20 to 32,000 patients in about more than 40 provinces, and with the it's still a lot far from the target set by the government. By the year 2016, we would have 80,000 patients on methadone. We still have about 50,000 short, but we really see over the past 2014 and 2015, the numbers really jump at a very, very high level. And this is the map of where methadone coverage in Vietnam, and the red is the one that don't have yet any clinic. The blue one is the one that has the more than 80% coverage, the target set up by the government, and the green are the one that have close to about 60 to 70%. And some of the provinces that we will hear story about have now 60 to 70% coverage by the government, target by the government. And this is the study that we recently completed to compare the methadone patient over 12 months versus the people who return from compulsory centers, and it clearly shows that methadone have really helped people to stay away from drug use and using heroin in particular. And this is the result of urinary analysis. But at the same time, as the methadone expands rapidly, we are facing with a new, probably a new epidemic, in my view, which is the epidemic of ATHS, or methamphetamine use. And some of the, we don't have data now, but some of the reports from methadone doctors and methadone clinics show that there's like 10 to 20% of the patients have now turned to methamphetamine use, and that would be a challenge for us in the next few years. In terms of the, now I want to turn to the linkage of care between methadone and HIV. It seems to be very well connected that most of the, this is the data from 2012, that most of the HIV positive are receiving ARV, right, about 70%. That's a very good, very positive indicator of good integration. But if you look at the other way around, once people are initiated ART and whether or not they are easily transferred or connected to MMT, that's another story. And this is the study that we have just completed and starting to analyze data in two provinces, in Thái Nguyên and Thanh Hóa. And among the ART initiated HIV positive IDUs, at the baseline about 40% in Thanh Hóa, and Thái Nguyên and Thanh Hóa 24%. But after 6 months, the percent doesn't change very significantly. And this is something that we have to really look into, how difficult it has been for people who on ART but then transfer to methadone clinics. I want to mention that the ART has expanded very rapidly over the past 10 years as well. Now we have reached about 40% of the patients that are in it, and we have about 90,000 patients on ART. But if you look at some of the information that reflect the disadvantages that IDUs entering ART, first of all, you can look at the cascade of care by gender, right? And we know that most of the people who are on ART T and male on ART are people who have injection drug use history. And you see that the clearly male has much more disadvantages in terms of linkages to care. And this is, although by the time they register with the OPC, most of them equally have equal chance to women in terms of receiving care, but they lost, many of them were lost at the earlier stage, at the stage of diagnosis, but also especially at the stage of registration with the OPC. And that's not a new story. This is this data, service data from 2006-2011 that show the clearly IDUs who enter the ART have much lower CD4 count level at the serious stage of diseases progression, have TB, higher TB, HCV, and of course lost to follow-up during their treatment. And one of the challenges is that the people know their status very late. Here it's the data about the percentage of people who know their know their status, and IDUs clearly much more lower than MSM or female sex workers. The data, again, this is the study that we conducted in Thanh Hoa and Thái Nguyên, where we follow patients who IDU, HIV positive IDUs to initiate ART at different levels. I want to call your attention to the drop level from the time they initiated ART to the time that they, 6 months later, people who started with CD4 at a lower level also have a much higher drop-off as compared to people who start, this is all of them are HIV positive IDUs, right? And they have a much higher drop-off, 88, only about 12% of them drop out of the study, of the care, ART care, versus those who have CD4 enter treatment at the CD4 more than 350, and about 100, almost 100% of them stay in care. And clearly there's some kind of structural or social or other conditions that make people who enter treatment late, but also drop out much more than people who enter treatment earlier, right? And this is something that I think that we have to look into more details, and hopefully one of our study that I work with Didier and Nicolas will get funded looking into the reason for late presentation. Amid all of these challenges, we face with another big issue, which is the funding cut. Here, this is so the level of funding over the years, and you see that the peak funding, the highest number that we had was around 2010, and now it's declining substantially. Right? Although the domestic funding from the government is increasing, but it has not been able to keep up with the reduction in funding from outside. So how does that impact the services? Here, the number of needle and syringes for harm reduction distribute over the years. And we see that by 2013, probably affected by the reduction in funding, it's really dropped off at the almost like half level of the year 2012. And this is very worrying trend. Right? It's also affected the establishment of CBOs in Vietnam. This is the survey that we just recently completed among about 300 CBOs in 24 provinces in Vietnam. And you see that over the years, the trend is that the number of CBOs that support HIV positive people really going down because of the funding, most of the funding. So the number of CBOs is going down, right? The only group that has gone up over the past few years is MSM, which is the purple color here. And the number of IDUs group, CBO group, is sort of gone up and down over the past few years. So it's really reflect the way in which the support has been declined in the country. Because most of the CBOs here, as we know, that have been supported by outside donors. Right? And looking into the budget for these CBOs compared to 2014, 2013, we see that the only group that sees funding increase is among MSM, right? They have the highest percentage that we have seen increase in funding. The IDUs, we have seen a substantial cut, but not as large as the CBO that work directly with people living with HIV. And I think that this is something that we will have to think more about in the future when we start thinking about how to mobilize these CBOs to support studies or other our HIV prevention activities. Now I want to switch to the impact of this budget decline in terms of family. I'm not going to into a very detailed table here that like costing the number of visits and the number of cost per visit, but overall about for ART treatment now 75% covered by the state and by donor, and 25% of funding coming out from the pockets of the patient or their families. So it is projected that if the funding is short, is now we don't have any more subsidized for ART or other test services, then about 75% of the household will be affected by this funding reduction. And this is also similarly for methadone. I talked with Dr. Vân yesterday and found out that Ho Chi Minh City will soon introduce right now the patient only have to pay 10,000 dong. This is the cost that we calculated in Hai Phong. About 40% of the cost for patient now are borne by themselves or by their families. Right? And if we keep continuing to increase the cost of methadone, I think that now the patient would have to pay for the medication themselves. I think that the percentage we will see a much higher level. And all of that, I want to show you this slide of the study on the impacts of the changes over the 6 months of an intervention study of a group at UCLA. They measure at the 4 aspect of intervention of the outcomes of the intervention on the family and the HIV positive IDUs. You see that the overall stigma going down significantly for both HIV positive and HIV negative. Similarly for depressive symptoms for both groups. The tangible support, we've seen that HIV positive going up quite substantially over 6 months and really at the level of for HIV negative IDUs. But if you look at the caregiver burden reported by the family, the more they involve in supporting these individuals, HIV positive, the more burden that they felt is something that they have to shoulder. And this is, if you connected that to the data that I showed earlier about the financial burden, this is not just the financial burden, but also other burden as well. Then you will see that how much the family will have to shoulder once all of the support from outside have declined, including the support from CBO groups, right? In conclusion, in summary, I think that we have made a lot of progress in Vietnam over the past 3 decades. We are now coming to a very critical juncture where there's a lot of challenges in terms of how to integrate the services that we have, how to provide the services that are available, and even create a new kind of services, integrated services. But also we have to think about how to mobilize the existing support from the community-based organization, from the family, from other type of social support for the IDUs and the HIV positive, taking into account the fact that the funding from outside sources is going down, and at the same time we don't have a very good social welfare system to support this group. Thank you for your attention.
Merci. Est-ce qu'on peut prendre 3 minutes si vous avez 1 ou 2 questions? Giang, maybe 1 or 2 questions? Mademoiselle Carrieri.
First of all, I would like to thank you for this very impressive presentation. I have a question about at the beginning you presented the distribution by drugs use, by last drug injected or something like that. And I was quite astonished to see that there was just a very little proportion of heroin users, or maybe I'm wrong. So I think it's after that. No. There was so many data.
This one?
No, it was a diagram showing the distribution of type of injected drugs.
Yeah?
I think it's maybe this. Yes, 4%. Drug use in the past 30 days. It's among MSM.
Yes.
Thank you. You answered my question. No, because one rising issues, and at any rate, is the increasing use of stimulants, and this is really a problem because they use it by injection. There are frequent injections and so on. So methadone is, of course, not the best answer, especially because maybe many of these don't co-use heroin. Or so, what are you planning to do something for this specific population?
I think that a very important question. That I didn't touch so much on what I consider as the emerging epidemic of another type. Methamphetamine use in Vietnam. MSM is particularly vulnerable population when we have. This probably our study was one of the first that showed the high prevalence used over the past 10 days of stimulants among MSM. Of course, the frequencies of use, I have to stress that the prevalence versus the frequencies of use among the MSM in Vietnam is still far from a level that we have seen in other countries, in the US or other countries. So it's in a very early stage. We have to keep watching closely. But we have seen that people who, the methamphetamine is still smoking. It's not injection yet, but Didier may correct me because he has heard something else in Haiphong. The other group that I also want to call attention to is the methadone patient. You have many of our colleagues here from Ho Chi Minh City have reported that among methadone patients, 10-20% of them are now using methamphetamine, and that's really a big concern for the service providers.
Thank you. Gilles, tu as une question?
Thank you very much for the presentation. It's a difficult question I'm asking to you. We've seen on the slides the burden of hepatitis C among drug users. Do you have any information on what is going to be planned by the government to tackle this difficult situation among drug users?
I think that I would say that for the VAC, Vietnam Administration for AIDS Control, they're also very, very concerned about HCV, and I think that the leadership level, they are very interested in exploring the way in which to expand HCV treatment for IDUs. But other than VAC, I'm not sure whether other departments really concerned. In the Ministry of Health, really concerned about HCV among the IDU, among injection drug use. Most recently, if you look at the national plan for viral hepatitis, in control of viral hepatitis in the country to the year 2019, I think that it's very little mention of injection drug use and how do we address the epidemic. So I think that there's a very big discrepancy in terms of the attention of the government, of the Ministry of Health at different departments in this issue.